Welcome to Part 2, Complications of Pregnancy in the Second Trimester, regarding pregnancy-induced hypertension and therapeutic management. When a patient is diagnosed with PIH, decisions need to be made regarding how best to manage the situation. The actual cure of PIH is to deliver the fetus. However, this may not be the best for the mother and the baby. Perhaps it only benefits the mother. Management is based on the severity of the disease burden to the mother as well as her fetus. How well is this fetus tolerating the mother's disease? And what is the gestational age of the pregnancy? How likely is it that this mother will develop eclampsia? These are tough questions, and truthfully, we cannot predict which mom will or will not develop advanced disease. The earlier in gestation a patient develops PIH, the worse the outcome for the fetus if it has to be delivered. Even 2 extra days in utero can make a difference. Keeping that in mind, our goal for the mother is to control the hypertension and prevent development of seizures. Our goal for the fetus is to provide an adequate circulation through the placenta to optimize growth and development. If either the mom or the baby have a change in status that worsens, then we prepare for delivery. You can see on this slide the various assessments that must be made at the beginning and throughout the shift for a patient with PIH. If the patient is an LND, the blood pressure is monitored continuously. If she is on the antepartum unit, it is checked every 2 to 4 hours based on orders. Primarily, this discussion is related to the PIH patient in LND. Place her on her left side as much as possible. However, she still needs to alternate side to side to prevent skin breakdown, so don't forget this. Edema. There's a slide following that will show you how to grade the level of edema. And DTRs, another slide, are assessed at the beginning of the shift and repeated as needed. I posted a video on Blackboard that demonstrates how to assess DTRs. It is important to monitor urine output every hour. Many of these women have a Foley inserted. These moms are placed on strict I&O, especially when in LND. Every void is checked for protein via dipstick. You need to perform a CNS assessment paying attention to her mentation, DTRs, clonus, which is defined on another slide, pupils, especially if she is not alert, and her motor activity. Believe it or not, some of these women can have a stroke, so familiarize yourself with the signs and symptoms if you have forgotten them. You need to ask your patient if she is having visual disturbance, a headache. If a headache is present, where is it? What is the pain level? Is it constant, intermittent, throbbing, stabbing? Also ask her if she has epigastric pain. The presence of these symptoms indicates a more severe form of preeclampsia, transforming to eclampsia, and you need to worry about the development of HELLP syndrome. Monitor the patient's LFTs, creatinine level for renal function, CBC, particularly because you're worrying about HELLP syndrome, and the uric acid level. If your patient is on a mag sulfate drip, you must monitor the mag level. Therapeutic levels are between 4 and 8 milligrams per deciliter. The nurse needs to implement standard seizure precautions, so if you are taking care of a patient with PIH, make sure you do the 1-minute environmental assessment at the beginning of shift so you know you have everything you might need in case of emergency. Read the physician orders regarding medications in case a seizure occurs. We try to admit the PIH patient to a private room so we can maintain a quiet environment with low lighting and minimal interruptions. You need to cluster your care and enter and leave the patient's room quietly. The patient is put on a fetal monitor. Remember, this patient has fluid volume shifts to the third spaces, so is essentially volume contracted. Therefore, the nurse must monitor both mother and baby at all times. This volume contraction leads to decreased flow through the placenta. Any signs of distress in the baby, even if the mother is doing okay and is stable, may result in delivering the baby. If and when the patient is stabilized, she may be admitted to the antepartum unit. She should be transferred to a private room that is close to the nurse's station. We usually do a non-stress test once a shift and monitor vital signs, urine output, and give meds as ordered. If the patient needs to be delivered and is not in labor, we will administer medications to induce the labor. Induction of labor will be discussed during week 3. A vaginal birth is preferred over a cesarean section due to the increased risk of bleeding should this patient develop HELLP syndrome. As the labor progresses, the nurse needs to provide pain relief. It is very important to minimize elevation of the blood pressure simply due to pain. So we either give IV narcotics or provide epidural anesthetic, which will be discussed in either week 3 or week 5 of the course. The next 2 slides demonstrate how to assess edema and to classify it, as well as defines clonus. When you've finished watching those 2 slides, go on to complications of pregnancy in the second trimester, PIH Part 3, for continued therapeutic management.